This is new. This is different. This hasn't really been talked about before. In a sense, this college is leading the way, as Vanessa has said. And what we need to do is have a good idea of what sustainability means in mental health. We need a direction. We need a way to move forward. And we need a way to start a conversation. So it would be great for you to have your pens at the ready and your thinking caps on throughout the day. And if you do have some thoughts about some things that are being mentioned, then just pop them. Oh, there's a board at the back there. And if you have some views that you'd like to share, please do in the breaks speak to Peter here, who I think will be in that room there. So, what is sustainability? It's a 6-syllable word that causes a lot of confusion, and certainly it's very interesting being a sustainability fellow because you spend a lot of your job explaining what you do. There are certainly positives and negatives about having an ambiguous job title. It's quite amusing at times. But what is sustainability? The outline. What is sustainability? How does it relate to healthcare? Why do we need sustainable healthcare? And what on earth does it look like? So what is sustainability? Well, essentially it's the capacity for something to endure. That's what it means. But what about an organisation? When we're thinking about sustainability as an organisation, what does it mean? Well, a chap called John Elkington in the 90s in corporate America came up with the idea of the triple bottom line. Now, the idea is that for an organisation to be sustainable, you've got to think about the impacts that an organisation has and the resources that an organisation uses. And he defined these 3 domains as both the places where we get resources and the places where we have impacts. And that is in an economic sense, in an environmental sense, and in a social sense. So I'm going to go on and explain that in a bit more detail. But the triple bottom line is otherwise known as the 3 Ps: people, profit, and planet. So when you're thinking about any organisation and the ability for any organisation to be sustainable, then you need to think about the triple bottom line. So sustainable healthcare, what are we trying to achieve in sustainable healthcare? What do we want to endure? Well, we want to endure high-value healthcare. We want to endure good quality health for the community and for the nation. So it's about ensuring that sustainable healthcare is there, despite the constraints that are pressing on healthcare. So it's the ability to provide good quality healthcare today without compromising the ability of future generations to provide good quality healthcare. So it's about thinking about the constraints in the triple bottom line framework. So here we have the Warneford Hospital. This is the hospital that I'm based in Oxford. And we have 3 swag bags. You can see 3 swag bags there on the left-hand side. So we can see that we need financial capital to get the healthcare running, going, employing people, buying things. And increasingly, we need to think about our financial impact. So what are the interventions costing? Because we know that with foundation trusts, we are given a set amount of money for a service. So if we can manage to make it cheaper, then we have money to spend on other services. So financial impacts are becoming increasingly important in this, with healthcare reforms going on at the moment. But what about the environmental swag bag that we've got here? So environmental resource that we're using is very significant. We need resource to build the buildings, to buy the medication, to buy the equipment, to buy everything that you see. There's a lot of environmental resource that goes into that, a lot of precious metals, a lot of precious resources. We also have environmental impacts, which I'm going to talk about in a bit of more detail later. But that includes the emissions from heating and also the emissions from fuel and travel and things like that. So you can see the environmental resources and impacts of a healthcare organisation. What about social aspects? Well, the social resources we use are staff, and the social impacts we have are on patients. And I'm going to talk about that a bit later in a bit more detail. So I've got a really pithy example for you here to try and get the message in, because it is quite complex. It is very broad the sustainability concept. So this will hopefully get you thinking sustainably. So we have a mental health hospital there in the middle. And I'm going to talk about a mental health admission. Now, a mental health admission, in the right circumstances, for the right person, is a good quality intervention. For somebody with acute psychosis, to have their psychosis treated and for risk to be reduced, it's a good quality intervention. But what does it cost? Well, the average inpatient bed day costs about £430. And most people stop there. We usually say, well, that's a good intervention and that's a reasonable price. Let's do it. The medics tend to go as far as, is it a good quality intervention? The service providers then go, well, how much does it cost? But generally, the service tends to end there. But the question of whether it's sustainable isn't answered yet. So we need to think about the other elements of the triple bottom line. So what's the environmental cost of an admission? Well, we know that the carbon footprint of your mental health admission actually is 480 kilograms of carbon. Now, what does that mean in common language? That means driving in your average car from Land's End up to John O'Groats, down to Land's End again, and then halfway back up. There's quite a lot of carbon. It's a carbon-intensive intervention. And when you think about the NHS as a whole, I don't know how many of you know this, but the NHS is the largest emitter of greenhouse gases in the public sector. It emits 25 million tonnes of carbon a year. And if you look at some Eastern European countries, like Slovenia, for example, or Estonia, the NHS has a bigger carbon footprint than whole countries, like those sort of countries. It's a really big emitter of carbon. What about the social elements? Well, we know that in some triage, acute triage wards in London, they are dominated by bank staff because actually they're really stressful places to work, and you get high turnover of staff, so you have to question about whether the social sustainability of wards like that are being affected by staff stress levels. What about the social costs of an admission? The social costs of an admission are for the patient. They might lose relationships, they might lose employment, they might lose their housing if they're in an emergency housing. So when we think about an admission from a sustainable perspective, we need to incorporate these other impacts that the admission is having. So is an admission sustainable? Well, certainly in the right circumstances, it's exactly the thing that we want to do and we need to do. But it's certainly also resource intensive. And these are the kinds of questions that we need to start asking ourselves when we start thinking from a sustainability paradigm. And from this point of view, sustainability is the whole truth. It looks at the whole spectrum of impacts that we might have in our clinical work. So what does that mean in a broader sense? Well, what certainly isn't sustainable is when chronically unwell patients are filling up our service and aren't getting better. So we have an overburdened healthcare system. And certainly in a system where healthcare might be commissioned by levels of activity of care, there is no motivation to really get people off the books, to get people out, because we're getting paid according to what we do. So we want to do more, don't we? A sustainable healthcare system looks at things completely differently and tries to focus on what does a healthy community look like. In order to maintain mental health in the community, what do we need to do? What structures do we need to put in place? What networks do we need to develop to maintain mental health in the community? In a sense, thinking sustainably moves you from thinking about from an individual, from an illness, and from an interventionist perspective to a community and a health perspective. And a really good example of that is the Barefoot Doctors in China, an initiative started by Mao, Chairman Mao. So what did the Barefoot Doctors do? Or how were they paid, more importantly? How were they paid? They were paid by every member in the community that was working and was healthy. So it was the Barefoot Doctors' motivation not only to get everyone well as quickly as possible, but also to ensure that they maintained their health for as long as possible. So again, another slightly pithy example. One Barefoot doctor noticed that everyone had a backache and was slightly depressed. and they thought, oh my goodness, my pay packet is halved. Everyone stopped working. And so they went to look at the canal that was being built in the local community, and they realised that they were all using shorthand shovels, and they were all working separately. So it was in the doctor's interest to think about that and think, well, if we increase the length of the handle and get everyone working in groups, hey presto, we've got people without bad backs and who are no longer depressed. So that's a really sort of pithy example of how a sustainable doctor has a shift of focus. They're not necessarily thinking, how do I get rid of this depression by giving another tablet or giving another intervention? How do I get rid of backache by doing something more? They're thinking, what's the root of this? What's the cause of this? How can I change what's happening in the community to ensure that people aren't getting unwell in the first place? So that's the Barefoot Doctors. So sustainability has these three domains. There's a lovely Venn diagram for you there, and hopefully you can all see that we need all three to be sustainable. But if you don't have the social element, for instance, you might have a viable healthcare system, but not perhaps a bearable or an equitable one. And equally, if you don't have the environmental aspects, you won't have a bearable or a viable one, but you might have an equitable system. So we need all three in that spot in the middle, the sustainable healthcare model. So I'm just going to touch on these other two elements, the economic and the social, before I get to environmental. So when thinking sustainably, why do we need to think about this in healthcare? Well, financially, I'm sure you all know this. This is NHS England. There's a £30 billion gap between costs of healthcare and the financial resources that we're going to get over the next 10 to 15 years. So that's a real issue. Something has to change. And as Muir Gray says, I don't know whether you've heard of him, but he's a sort of guru for healthcare and thinking about future healthcare. More of the same is not the answer. Something needs to change. The money has run out. And that graph can show you there the difference, the £30 billion difference there. Okay, what about social sustainability? Well, what happens to somebody socially when they become unwell? As I've mentioned, they might lose employment, they might lose relationships, they might lose a sense of connectedness with their community. So social sustainability is about ensuring that healthcare organisations have a responsibility to restore that social capital that is lost through mental illness. Not only does this improve mental health resilience, but it also is a very important aspect of providing, well, the broader elements of care. So what's social capital? You can divide it in hard terms and soft terms. So hard terms are housing, employment. The soft terms are opportunities that people have to meet people, to be educated. And soft terms also include community connectedness or fear walking about in their community. So that's what social capital is. And so social sustainability is about restoring social capital. And actually, very importantly, psychiatrists are good at this. And the personal recovery model is the thing which each of us as individual clinicians can use to ensure that we are helping our organisation achieve social sustainability. Because the patient defines their recovery in their own terms, they will think about things like jobs, they will think about things like relationships. They won't just think about symptom reductions. And the core tenets of the personal recovery model are hope, agency and opportunity. And traditional models might be able to address both hope and agency of an individual, the ability for somebody to make decisions. But do they address opportunity, the opportunities that are available in that community for somebody to get well and stay well? I'm not sure. And I think this is where this extra role of a socially sustainable service needs to grow into. And equally, the disability model provides you with an example of this. A disability model talks about the factors which impede somebody from living independently. So there aren't just illness factors that stop somebody living independently. There are also personal factors, perhaps like loss of confidence, like motivation, perhaps like obesity or something like that. But there are also societal factors. So there's illness, personal and societal factors. And actually it's these societal factors in the community that might be affecting independence. And when we think about social sustainability, if we look at the current social society, one thing that I struggle with about the NHS is an amazing thing, and I think it's a lot less wasteful than a lot of other healthcare systems. But the trouble with having a nationally provided service is that it can engender a sense of dependency amongst the public. My health is your problem. And that, coupled with the fact that we have an ageing population, a rise in long-term comorbid health conditions, and increasing expectations, are all going to increase the demand on services. So how do we maximise independence? And I argue that if you think socially sustainably, you would think about creating opportunities in the community and also thinking about these societal elements that are impeding independence. That's what social sustainability is about. So let's get back to that Venn diagram and environmental aspects of care, the forgotten part of mental health. So just a question, do you prefer living under a moral imperative or a legal imperative? Do you like to make clinical decisions because you care about the patient, you want them to get better, or because you're concerned about what the GMC might do to you? Do you prefer to be hit by a stick, or do you prefer to chase a carrot? I think I would hope that we'd all prefer chasing carrots and working with a moral imperative. And the question is, do we need to think more sustainably because of a moral imperative or because of a legal imperative? Well, actually both. We've got both a moral and a legal imperative to think more environmentally sustainably. So what's the moral imperative? The moral imperative is climate change. Here we see from the 1970s, global climate change, global temperature, increases. That's on the right-hand side of the graph there. You can see it really skyrocketing. It's a reality, and I was just wondering, does anyone know what might be happening in the middle of that graph, that little peak around the 1940s? Do you know what that might have been due to? The World War? Yeah, the World War. So that little peak, that's what happens when you burn a lot of carbon. Okay. And then we have the graph going up at the end when we really started doing that on a major scale. So why do we as doctors need to be bothered about this graph? Isn't it, sort of environmental scientists and politicians' responsibility? Well, a video that we're going to be shown later is by a professor called Helen Berry, who's come up with some really important research looking at the direct mental health effects of climate change. And here we have one of her studies, which is showing the effects of drought on mental health in rural populations and urban populations. And here you can see on the left we've got rural populations, and as the drought gets worse, this was in Australia, by the way, where they had a 7-year drought in the early 2000s. As the drought gets worse, the psychological distress increases. Urban populations, interestingly, that wasn't the case. They were enjoying cocktails by their swimming pool. But the rural populations were grossly affected, so perhaps an initial sign of that. So climate change has effects on mental health. And in fact, the WHO, the World Health Organization, and the Lancet Commission have both stated that climate change is the largest threat to human health in the 21st century. That's big. That means that climate change for today's generation, tomorrow's generation, is the TB, the AIDS, or the malaria of their generation. It's interesting that we're not talking about this and we're not engaged with this as a profession, given the extent of the concern, really. And we're going to perhaps be hearing a bit about the denial that goes on about climate change from Judith later on today. And as I mentioned, there is increasing evidence that floods, heat waves, drought and cyclones all impact on mental health. We've got another researcher down the front here who's written a paper on the effects of flooding on the older adult population in the UK. So yes, and as I've mentioned before, the NHS contribution is significant. Healthcare organisations have a big carbon footprint. So the moral question is, if climate change is the largest threat to human health in the 21st century, what are healthcare organisations doing contributing so much to greenhouse gas emissions, which is one of the main contributor of climate change? What are we doing? That's a moral question we have to ask ourselves. I'm just going to skip past that. The legal imperative is the Climate Change Act of 2008. We are legally obliged to reduce our carbon footprint by 80% by 2050. We've got a long way to go. Again, why are doctors involved in that? Why shouldn't we just leave this up to our health and estates facilities people? Can't they just put some windmills up and get us all on renewable energy? Well, it's not as simple as that. And this is the carbon footprint. We can see that 61% of that is procurement. That's the stuff that we buy. That's the things like medication, medical equipment. In fact, the graph looks like that. The vast majority of the carbon footprint of the NHS is due to clinical factors. The biggest single component of the NHS carbon footprint is medication. When we think about the fact that 10% of the carbon footprint of mental health could be due to medication that is thrown away. And we know that because some studies say that up to 50% of medication for people with long-term mental health conditions aren't taken. And pharmaceuticals is 22% of the carbon footprint. So that's a big issue and potentially low-hanging fruit. But what does it look like? What does sustainability look like? I've given you the facts. I've talked a bit about the concept. I hope you're all with me with understanding what sustainability is, that six-syllable word of confusion. But I'm just going to talk a bit about what it might look like for other specialties, because I think this can give us a bit of a helping hand in mental health. My job would be a lot easier if I wasn't a mental health sustainability fellow. If I was a nephrology fellow, I would just focus on dialysis. And why would I do that? Because it's economically, environmentally, and socially very costly. It costs a lot of money, it uses a lot of environmental resource, and it's socially costly. People have to give up hours every day or several days a week to be on dialysis. So that's a really unsustainable intervention. If I was a respiratory sustainability fellow, it would be easy again, or easier. The carbon footprint of the aerosol inhalers for asthma contributes 6% of the entire NHS carbon footprint, because they're exempt from the CFC regulations in the 90s. So what do we do in mental health? And this can be quite difficult because there isn't necessarily these really big things or single thing that we can change. So let's go back to thinking about the triple bottom line. We can know a bit about those constraints, the impacts that we're having, and we need to think about models of care. How do we do that? Well, the Centre for Sustainable Healthcare has come up with principles of sustainable healthcare, and we know them to be prevention, lean service design, patient empowerment, and use of low-carbon technologies. The best thing we can do is be preventative. Like with the barefoot doctors, we need to think preventatively. The most sustainable mental health service is the one that doesn't need to be there because the community is so healthy that we don't need to have resources for healthcare. But we need to lean down services. We need to think about empowering patients. I wonder whether there is a sense that people are empowered by technology, by using social media, by having access to all that information they've never had before. I wonder whether we as psychiatrists can kind of jump on that bandwagon a bit and get people more able to manage their conditions through educating them, through providing networks, peer support networks, carer support networks, helping them signposted to the right community support structures, get them empowered using this sort of social movement. I don't know. But I think what it comes down to mental health, and thinking of my sort of job as a sustainability fellow in mental health, in psychiatry, I think it's about a paradigm shift. It's about a culture change. I was taught when I was doing psychotherapy in Oxford to not only have my medical hat on when I was sort of diagnosing and intervening in psychiatry, I was also told to have a psychoanalytic hat on, thinking about the transference and the emotions in the room. But I think we also need a third hat, that of a steward, being a wise steward of clinical resources, thinking about the impacts of the wider health system. And that's what I think it comes down to in health, in mental health. And something I think maybe we need to talk a bit about today. So I'm going to try and give you, again, something to throw your hat on. And these are some things that I've sort of been working on a bit this year. So can we target 3 areas? Can we reduce waste? And when I say waste, I don't just mean bin waste. I mean waste in clinical care. Perhaps doing a diagnostic test that isn't necessary. Perhaps admitting somebody when there's another route or option available. The thing which kind of gets my goat sometimes is the fact that what is sexy in medicine is what has a long name, is unusual, and very few people can do it. So you get people, neurosurgeons are very, very cool because they're doing things with really long names that nobody else can do, right? And that kind of leads to a culture where the more we do, the more blood tests we do, the kind of more unusual blood tests we do, or the more unusual, more expensive scan. I did a scan the other day, it cost this much. Oh, wow, that's incredible. That sort of thing. That needs to change. And I think it would be great if we had a culture where one junior doctor said to another junior doctor, you know what? Every single blood test I did was completely necessary. But you know what? I didn't do anything more than I needed to do to get that patient well. And if we can get into a culture where that's actually the sexy thing to do, that's the cool thing, that will get you respect. That's a really sustainable way of thinking. I don't know. If you've got any ideas about that, let me know. But I think that's also a reason why psychiatry isn't necessarily the most cool specialty when medical students are looking at professions, because actually psychiatry is about getting your hands dirty. And it's about the simple interventions. It's about making sure the social networks are there and that person feels cared for and understood. Now, people who aren't medics can do that. Whereas we don't have these, well, we do have some German names for some of the psychopathology, which maybe are still quite cool. But, I think that perhaps that's one reason why, I don't know, coming to psychiatry is eating a bit of humble pie sometimes. But anyway, I've gone off on a bit of a tangent there. We need to reduce wasteful practice. We need to review how we deliver care and what care we deliver. So, reducing waste in depot prescribing. There are 2 potentially wasteful activities when we prescribe depots. That's prescribing them too frequently and at a dose that is too high. I've looked at a flupentixol decanoate depot, and the average prescribing interval is 2 weeks. Now, the Maughan prescribing guidelines say that intervals should be the maximal possible, and that's to reduce pain for the patient. But it could be as much as 5 weeks, but the average is 2 weeks. And the dose, which they say that the evidence suggests that gives maximal efficacy, is much lower than the average dose given across the country. Now, I agree, in forensic settings, there are lots of reasons why you might give higher doses. But what I've done is I've did a little audit of prescribing practice in Oxford Health. And I looked at the costs of the medication overspend from the maximum efficacious dose or effective dose compared with what the average dose was. I've looked at the cost of the needle and syringe, the appointment, and the travel. I've also done a carbon footprint of that. And what we've realised is that if you actually follow best practice, then there's a lot of savings that can occur. Nationally, we can save almost 200,000 kilograms, or 200 tonnes of carbon. That's equivalent of driving a double-decker bus, a couple of times around the world. And we can also save £500,000. That's just a really simple example. This is trying to get the ball rolling, trying to get us to think about the whole truth of the interventions or the impacts we're having in our clinical decisions. So that's a little thing about reducing waste. The next thing is about reviewing how we do things. This is a busy slide. Apologies for that. But treating depression in primary care. If you take out the last 2 columns, Those first three are directly from, copy and pasted from the NICE guidelines for depression. And what we see is that the cost for treating severe depression is 600 quid. The treatment is just over £1,000, and the treatment for online video face-to-face is £1,000 as well. But let's look at the carbon footprint. Well, we can see the carbon footprint is about 900 kilograms of carbon for treating depression with psychiatric reviews and medication. That's one medication, not two medications, by the way. CBT actually is more carbon intensive. Why is that? That's because of the travel and the increased appointments, so the building and energy use going into that. So that's more. So medications aren't necessarily the bad guys here. If we look down at the bottom, online video face-to-face CBT, perhaps unsurprisingly, has a greatly reduced carbon footprint. In fact, 20% of face-to-face CBT. So technology isn't a panacea. Nothing will replace face-to-face interactions, but there is a sense that we need to review how we do things. I was speaking to somebody in the Child and Adolescent Royal College conference a couple of weeks ago in Cardiff, and he said that once he's done a full assessment and started somebody on a medication, he does phone reviews every week, and unless there's a problem, he won't see them for 3 months because he touches base with them over the phone. That's a really interesting way of reducing resource. How we do things needs to change, but also what we do. So, social prescribing is something that there is a seminar about, and we have the honour of having Dan Bloomfield here, who's an academic thinking about green prescriptions in primary care for mental health. But social prescribing is essentially where, instead of prescribing perhaps a medication or therapy, or perhaps alongside, you can prescribe a group, a walking group, a gardening group, perhaps something like Time Bank. Time Bank's really interesting, where if you put an hour in of whatever activity you do, whether that's washing or clearing up, you can have an hour of somebody else's time, perhaps a psychologist or a mindfulness therapist or something like that. So I did a sustainable analysis of a social prescribing service in a GP practice up in Grimsby, where essentially there was a link worker, and the link worker could link people with mental health problems up to community groups. And what we found was that this is the carbon footprint. We looked at GP appointments, we looked at secondary care referrals, and mental health medication. We found that those went down. And as a result of that, the carbon footprint of the primary care practice went down as well. So here we have average reductions to carbon footprint of healthcare per patient per 6 months. And we can see that after being in there for 18 months, we have a reduction of about 30 kilograms of carbon per patient. So that's really good. That's quite interesting, isn't it? We have and we can see that there is a carbon neutral service for healthcare. When you look at the previous carbon footprints of antidepressants or CBT, you can see that this is a really good sustainable way of thinking about managing depression in primary care. So that's my talk over. I just want to finish with this summit consensus statement. This I want to be seriously mashed up over the day. I want you to think about it and think about what you can add to it, what you want to take away from it. I would like this consensus statement to be something that we all share and we can all bring to our colleagues and talk about. I know that sometimes when I began my job, or perhaps before, when talking about sustainability in mental health, they say, well, what's that about? It's quite difficult to start a conversation, so I hope this consensus statement will do that. And I'm going to put that up now and just read it to you. So, sustainability in mental health is the ability to provide high-value care in the face of economic, environmental and social constraints. So we've all got that. We all know that now, right? So Sustainable Care Act 2, prevent future relapse, empower patients to self-manage, eliminate wasteful activity, and where available, make use of low-carbon alternatives like eCBT, like online clinics or phone clinics, or maybe social prescribing. And then reducing over-medication and poor compliance, making use of ecotherapy or online CBT, and nurturing a thriving support network are all examples of actions that can improve patient care whilst reducing economic and environmental costs. That's a consensus statement that I've come up with a couple of colleagues. But I really would like Phil at the end of the day, Phil down here, who's sustainability lead for the college, is going to have a session at the end where perhaps some of our thoughts have been reflected and that consensus statement has been changed. So please do input into that. Or if you just like it, say you like it. But that's me, and thank you for listening.